Good afternoon. I'd like to invite everyone to come and take a seat, please.
All right, good afternoon, everyone. We're going to get started with our next session. Hopefully everyone has been having a good time so far, lots of education, I think lots of good discussion that is happening all throughout. I'm hoping you can bring the same energy to our breakout sessions tomorrow. So my name is Emily Methangkool. I'm an anesthesiologist and a member of the board of directors of APSF, as well as a member of the Stoelting Conference Planning Committee. I'm very excited to present our next session, which I think is really important for our discussion on medication errors, and that's the intersection of human factors with medication safety. So I'm joined today by an esteemed panel of speakers. We're actually going to start off with Dr. Matthew Weinger, who is an academic anesthesiologist and human factors engineer. He has a long record of research and publications and lectures on quality, medication safety, and human factors engineering. He was a secretary and member of the executive committee of the APSF from 2005 to 2020, and he will be speaking on human factors consideration in medication safety. What is the evidence? Dr. Weinger?
Thank you. So I have a short video and it didn't work, so we're using the computer. And it looks like we'll see if this works. So how many people in the room know what human factors engineering is? Raise your hands. So a pretty educated audience. I'm still surprised, despite a lot of people's effort for 20 years or more associated with medication safety, that a lot of people don't know what human factors engineering is, or they say, oh yeah, that's how the humans screw up the system. So I was asked to give an introduction to human factors, but I'll do that very quickly for this audience, and then we'll talk about some other related things. So I'm a consultant for Fresenius Kabi for the Ivenix infusion system. Probably isn't a relevant conflict of interest for what I'm going to say, but it's relevant to this audience. So the definition of human factors engineering is that it's a formal study of human interactions with tools, devices, and systems to enhance safety, as well as effectiveness, efficiency, and user, and for medical devices, patient satisfaction. And it's been widely applied since the 50s to a wide range of industries. And for this audience, probably everyone has read Don Norman's book, but that's the one I usually use as a recommended introduction. So this is the kind of thing we're talking about here. Fumbling for his recline button, Ned unwittingly instigates a disaster. So, sorry, there was a pop-up on my screen which blocked what I was trying to see. So another technology usability issue. So you can see wings stay on, wings stay off. That's not a good design, right? Everybody agrees with that? So what is a user interface? And actually one of the previous speakers introduced this, so I'll say it quickly. Any aspect of a system, process, or device with which a human can interact. And it includes the recipient of the action. So AI on working on patients, even if you don't have anything to do with it, part of that user interface is with the patient. It includes hardware, software, documentation, labeling, packaging, training, etc. And with regard to a medical system, users include clinicians, cleaning personnel, maintainers, patients, lay persons, the shipping personnel who might cut themselves on the device, etc. And it's really relevant. This is an old infusion pump that had caused a major harm event where a patient was critically ill and there was a significant delay in therapy because, anybody want to shout out why? They had programmed the epinephrine, and they inadvertently hit the off button instead of the start button. And this system then had a pop-up, didn't do anything, and a pop-up said, you sure you want to stop? And they didn't see it, and there was delay in therapy. So the take-home message is that the vast majority of adverse events associated with the use of medical technology is due to poor user interface design and not inherent failures of the technology, software and hardware. Now, today, later today, you're going to hear about lots of solutions to our medication safety problem. I view these as tools, and tools can be used well and not so well, and they can be designed well and not so well. And I would argue that none of these current tools are well designed, and technology alone, especially those associated with tools with poor UI design, is not going to solve our problem. You need to take a bigger view. So I want to reframe the discussion of error next, and then we'll talk about systems approaches. So at our institution, we don't talk about errors. We talk about events, and humans always play a role in events. It may be the human on the point of care. It may be very far upstream. But 25 years ago, I stole from nuclear power the concept that any deviation from standard operating procedure is worth investigating. And so we called it a non-routine event. And in healthcare, it's reframed as any deviation from an optimal care path for that specific patient and their outcome, which may not be a return to normal health, but it's certainly, you don't want it to be a degradation in health that it wasn't intended. So there are all these factors that we heard about. Very nice talk from our resident in the last session. We call those contributory or performance shaping factors. And what we study is the occurrence of events usually associated with contributory factors that result in a deviation from optimal care. And when that happens, there's a risk of an increased risk of adverse outcome. And with multiple ones, the risk will get larger. And so what we all do as healthcare professionals is be on the lookout for this. And we look to intervene and rescue or recover to bring patients back to optimal care paths. Giving phenylephrine when the patient's hypotensive is an example of that. And as an aside, a colleague at NASA did a study a few years ago that showed that 20% of all commercial flights, as reported by pilots, have some event that if they didn't detect and do something about, could have resulted in an accident, just to make you feel good about flying home. So I'm going to talk briefly about safety 1 and safety 2. And the fundamental difference is safety 1 mostly is unfortunately after the fact, what went wrong and what can we do to fix it. Safety 2 is about how do people fix systems or make systems work despite all their flaws. So we've studied thousands of cases of non-routine events, and the overall incidence in perioperative space is 20 to 30% of all cases have at least one non-routine event. In our 2007 study, where the 181 cases that we observed and video recorded, 15% of the non-routine events were categorized as being drug related. Now, the drug may have been the precipitating cause. There are lots of different things, but drugs played a role. In our 2020 study with 512 cases, 13% of NREs were categorized as drug related. And we have hundreds of thousands of video recordings, but hundreds of examples of videos. Like this is just one of them. This is a case where there is clearly documented preoperative lidocaine allergy. And you're going to see in the video, which doesn't have audio just for simplicity, since I didn't think it would work, but it has subtitles, that lidocaine was in fact given during induction. And that's at 7 minutes. And then 11 minutes later is the timeout, which is supposed to prevent problems. And the surgeon says he's allergic to lidocaine, and the anesthesia person snidely says, we'll have to remember that. It was a swelling allergy. So I think Karen may talk about preventing drug allergy or giving drugs for allergy, but that's just an example of many types of intraoperative cases. Now, Dr. Greenwood was very nice to introduce the vecuronium instead of Versed case that was criminalized. And I want to make the point that while there are lots of things that the prosecution pointed to, what I would call active failures of how the nurse in that situation, who, by the way, beforehand was a very good nurse and in fact was busy, was considered good enough to be taking care of a trainee nurse at the time, that they had to leave up in the unit while they did this, but that there were 7 times more latent factors than active failures. And the take-home message here is that improving safety in complex systems requires a different approach than we've been using. So I want to talk more about safety 2. Like safety 1, it's a systems approach, but it incorporates complexity theory and resilience engineering. And it focuses not on that part of the system, whether it's a person or a piece of equipment is broken. Not to say that isn't important, but where you are able to create safety is on the relationships or the communication between the parts. And this is especially problematic when you see local unit optimization. For example, events that are shown to be related to patients that go from the emergency department to the OR, it's the local optimization either in the emergency department or the OR for their priorities that lead to miscommunication, broken relationships, and ultimately to errors. Safety 2 respects clinician expertise and engages them, and thus success is as important, if not more important, to study than failure. So let's finish talking about design. When you have a problem, how do you know that you have a problem? And from the perspective of design, for you in the OR, if you have interruptions by doing whatever you're doing, frustration, self-doubt, there are more non-routine events, you're going to have increased risk of failure. And in contrast, when there's good design, the technology is invisible. You have flow of your care. You're more satisfied. You're more confident. Recovery is more likely to occur, and there's a decreased risk of failure. How do we achieve good design? With human-centered design, which starts with a deep understanding of what frontline, we'll say clinicians, do every day, both for routine and non-routine cases, to then deliberately design the thing based on requirements, users' needs, and iterate it using simulation often, and then evaluating it before you implement it to also design the implementation, which is often, especially for software, a source of failure. And continue with post-deployment review. So with regard to medication safety, we have to look at the whole process. The people, including the patients and their family, the processes, maybe using the STPC framework that APSF developed years ago, all of those tools, and we have to understand the context because none of those alone is going to solve the problem. So my take-home messages are: 1, consider the system as a whole, including culture and leadership, which is so important, and we still haven't figured out how to make that work. Even when they're broken parts and you're trying to fix them, take the big picture view. Use safety 2, how things go right, in order to better understand how to make the system more resilient, more adaptable, and more likely to recover. Value and harness frontline clinician and other expertise. So when people make mistakes, the question to ask is, how many times, because there'll be many times, did this not happen because other people figured out how to prevent it from happening, and let's learn from that. Design technology so it's a well-communicating partner that helps meet users' needs during actual use, which means the engineers can't be the only ones to build something. They can't be running the asylum, as a well-known book talks about. And then one other thing is, it makes sense to standardize, but you've got to be flexible and adaptable, especially in more complex non-routine situations. So if you standardize and take all the flex out of the system and penalize people who deviate from the standardized protocol, you're going to create more risk than reduce it. So thank you very much. This is What I wish we had in the OR, a safety meter, we don't. The safety meter is all of you. Thank you.
Thank you, Dr. Weinger. We could get the rest of the presentations up, please. There we go. Our next speaker is Eliot Grigg. He is an associate professor of anesthesiology and pain medicine at the University of Washington and a pediatric anesthesiologist at Seattle Children's Hospital. Dr. Grigg is a published researcher on quality improvement, human factors, and medication safety, and he will be speaking on feedback and constraint mechanisms.
Thank you. And thanks for having me. These events I just find are a really impressive group of people, and I'm just happy to be a part of it again after coming to the last one. So I wanted to talk a little bit about, this is a great introduction, talking about human factors in general. And so I wanted to kind of bring some of these ideas and some design thinking to bear on what we do in the operating room in a way so that we can start to think a little bit differently about how we might approach medication safety. This is just an analogy. I'm going to talk a little bit about constraints. Hopefully a relatable one if people have had TV remotes. This isn't my photo, I borrowed it, but my father-in-law did something similar, trying to understand how to cut out all of the unnecessary pieces so that you're left with what's useful. And it makes it much easier to do the right thing and cut out a lot of the noise so you don't do the wrong thing. So a current state of medications in the OR, anesthesia medication handling is very complex. We have several single point failures. We rely on vigilance and accuracy, which are two things we've already discussed the human brain is not most equipped for. And a lot of our countermeasures aren't really sustainable. And we've talked a lot about labels. Here's an example of poorly made labels. They require a lot of focus. They require standardization that we don't have. They don't physically prevent anything. And the big issue with labels is that they're trying to serve too many users. I don't care about 90% of the information on that label. If I had a pair of glasses that eliminated most of what was on a label, I could probably do my job a lot better. Because all I really want to know is what's the drug and the concentration per ml, and the rest of it is superfluous to me. Joyce and colleagues made a nice summary several years ago about all the medication safety recommendations from various organizations, including APSF, ISMP, and others we've heard about. And they identified 138 different interventions, which to me is really a red flag that what we're up against is really just too much complexity. Even when we put together the ISMP recommendations several years ago, it was a really useful process, and I'm proud of the outcome, but it was 30 pages long, which again, I think is a symptom that what we really need to do is think about simplifying and how to make things safer. So I like the analogy, I'm definitely pro color when it comes to the color or not debate. Originally when stop signs were first developed in the early 20th century, you did what you would probably do on day one. You made a big black square, and most people didn't really stop. They didn't really standardize. They were in kind of odd places. So over time, we developed ways that made it easier for people to identify. Now it's based on shape and color and location, in addition to what you actually read on the sign. So that's why it's standardized with stop lights are red, stop signs are red. They're things that they have done. So now at least when people run a stop sign, it's not usually because they didn't see it, but maybe for other reasons. We've talked as well about how our unique workflow is different from the rest of the hospital. A lot of people view that as a vulnerability, and it can be certainly, but I also think it's a unique opportunity. I think it's worth bearing in mind that the top workflow, which most of the rest of the hospital does, was not designed with safety in mind. I mean, certainly there have been interventions to try to make it safer, but it's really more of a manufacturing mindset of specialization and efficiency. And what we have down below is both a unique opportunity to try to really craft what we do that's different. And I don't think taking the wholesale lessons from the rest of the hospital is necessarily going to be the best solution. So several years ago, a colleague of mine, Liz Martin, did a failure mode and effects analysis looking at the medication process in the OR. Many of you have seen this slide before. I know you can't read it, and that's kind of the point. This was really prospectively looking at what we do every day in the operating room. We identified 5 major steps in terms of getting a medication from vial to patient, 19 sub-steps and 68 possible failure modes. So that again speaks to this idea that what we do is much too complicated, and really what we need to do is come up with ways to simplify it in order to make it safer, not necessarily add things on top of this. So again, this hopefully is a familiar slide to any of you interested in human factors. There's a lot to unpack here I don't really have time to get into, but the main thing I want to talk about is there's various levels of interventions that we can talk about. And things like education and rules are pretty low on the hierarchy of effectiveness. And things like forcing functions, constraints, automation are going to be much more effective, much more reliable, much less reliant on user participation, and ways to sort of force people to do the right thing, obviously with the asterisks of, within reason and in useful ways that work with their workflow. So we've talked a lot about the history of anesthesia safety, and hopefully most of you are familiar with all that work that was done in the 80s and 90s, looking at the machine when they identified that airway and oxygenation was the big problem. And so there was a huge amount of work that went into the anesthesia machine, designing it in a way that made it really difficult to deliver a hypoxic mixture. This is like Anesthesia 101, first day of residency. They go through all the various things in terms of how the flow meters are set up and the pin index system and all the various physical constraints that make it really hard in a modern anesthesia machine to not deliver at least a life-sustaining amount of oxygen. And yet on the other side of our workspace, we have very few of those today. We don't really have a lot of constraints that prevent us from doing really bad things. We've seen several examples this morning, some of which have been repeated over and over, which is a little disheartening. But hopefully after today, we can walk away with some ways to make that better. So we don't have ways to detect errors most of the time. I mean, if you give the wrong dose, it's usually something discovered much later. We don't have alarms about giving the wrong dose when you're bolusing medications. So starting to think about how can we make the medication side of our workspace start to look a little bit more like the machine side. So I think there's sort of 2 ways that are useful to think about this. One is sort of feedback versus constraints. Feedback is labels, it's alarms, it's various things that can be helpful, but does require a certain amount of engagement and a certain amount of compliance. A much more robust are constraints, which eliminate steps, automate processes, and ideally physically prevent mistakes. That may we may not always be able to get to that level of intervention, but again, conceptually, I think it's helpful to think about, are there ways that we can physically eliminate problems, things don't fit together, things like that. And so some examples, color-coded syringes provide at least some useful feedback, barcode scanners, labels, and provider checks. But really on the other side, you have more robust constraints like smart pumps that won't let you give a lethal dose of a medication. If you have standard pharmacy concentrations, then you're not going to have a bunch of other options that can create confusion. Prefilled syringes, I'll talk about a little bit more in a second, but that eliminate even this whole question of vials and vial swaps, et cetera. So a couple examples of constraints that we'll see around the operating room. Top left is the medication layout tray that we use at Seattle Children's and a couple other places around the country. The nerve fit we've talked about this morning, how you can't physically connect the wrong medication or at least the wrong syringe to a neuraxial catheter. Again, constraints on infusion pumps can be programmed in certain ways and have certain limitations so that you can't do something that's going to cause a lot of problems. I think another way it's useful to think about this is adding to an already complex workflow versus subtracting things away to try to simplify. So one of the things I worry about, we talk about this TSA analogy of you have airport security and then the next day you take your shoes off, and then the next day you take your liquids out, and the next day it's more and more, and it keeps getting more complicated. I worry a bit about some of the interventions that we've talked about. Barcoding at the point of administration, I think has value, but essentially you're asking someone to do something probably about 10,000 extra times a year for something that's not very common. And it's going to be a bit of an uphill battle to get people to do that regularly and consistently and make it part of their workflow. So I think it's more helpful to start thinking about, are there ways to subtract problems from the system? So one of my favorites is prefilled syringes. Going back to our failure mode and effects analysis and going through all the various steps, prefilled syringes alone will eliminate 6 sub-steps and 19 failure modes, just like that, just from those syringes, because all that vial preparation, vial swaps, all this TXA, phenylephrine things we've been talking about this morning, a lot of that goes away. It's not 100% foolproof, but now suddenly all these vial issues disappear, and it's a really robust way. You know, again, with the asterisks, we've been through 304, 503Bs, and we have supply issues, and there's other challenges. But I think it's useful to think conceptually of, can we take pieces of this system out? You know, can you make pharmacy prepare infusions for you so that that's not something you're doing in the OR? Like, why are we even doing all this medication preparation in the OR? If you couldn't, you would be hard pressed to design a worse space to be doing med preparation than an operating room. The other thing I just want to mention, there's a lot of med safety adjacent concepts that worry me. And I just want to sort of keep in mind when we're thinking about medication safety that we don't confuse it with other things that I found in my institution, particularly from the administrative side, often get confused with med safety. So sometimes we borrow ideas wholesale from somewhere else. So the two provider check, I think it can be very useful. We do it at my institution for local anesthetic specifically, but in an operating room, it may not always be practical. You may not always have two people around. You may need to find a solution that's going to work better. Again, barcoding, I think, can be valuable, has an important role, but it's not something I would want to take wholesale, pretending like we are the floor at that same pace and cadence, because what we do is quite different. I think the automated dispensing carts can be useful for a lot of reasons. I don't think medication safety is typically one of them. It's very helpful for wasting medications. It's helpful for pharmacy to keep track of things. But I feel like oftentimes administrators roll these new technologies in and say, look, it's going to make your practice safer, when I would argue it isn't necessarily. There's also these challenges of when we can't really get to the root problem. We've had several examples today of lookalike vials. I think this group is maybe uniquely positioned to try to make some headway, but for the most part, from a healthcare institution perspective, we have no control over supply chain shortages, what vials look like. And so we do a lot of things to try to prevent vial swaps, but as long as they come in this random rainbow of colors, it's going to be very hard and something, again, an uphill battle we're going to be constantly fighting. And then I think sometimes we do get overshadowed by other parts of the hospital or other priorities. You know, this whole back and forth about color coding is often less a concern about the operating room and more about the rest of the institution. And so because we are a relatively small piece of the medication puzzle, I think sometimes we get overshadowed by priorities in the rest of the house and not tailoring solutions to our unique workflow. And so the question I like to ask is, you know, why doesn't anyone talk about barcoding sevoflurane? It's because we have all these robust mechanisms that are in place, from the, you know, the key to fill it to measuring it as we give it and how much of all these other things. And if we could do more things like that on the IV medication side, then we might find we don't need some of these other additive interventions. So I just like, as a thought exercise, to sort of think about like subtractive questions in terms of how can we eliminate steps? Again, you know, eliminate vials, pre-filled syringes. Is there a way to eliminate syringes? You know, why do we rely so much on labels? Mental calculations is a huge one in pediatric anesthesia where I practice. I don't necessarily have a solution for all this. You know, we have various job aids and things, but again, just sort of thinking about how to unburden the user and how to simplify their workflow. You know, the interoperability issues about syringes and NERFIT and NFIT and all that. And then similarly, how do we automate various processes about drug selection, you know, concentration, so that we have, you know, the fewest that we are trying to deal with, automating recording, so you're not spending as much time interfacing with the EHR, you know, various other interactions, allergies, et cetera. So we talk about, you know, constraints, but useful constraints. Constraining to afford is a human factors term about, you know, making sure you can do the thing that you really want to do. So we're not trying to prevent you from doing your job. I mean, it's the job I'm trying to do as well, certainly, but trying to make it really hard to do the wrong things. And so today, you know, we talk about error reduction, simplifying, standardizing constraints. And I think tomorrow there's probably an opportunity to get closer to a much more streamlined workflow. Those of you who have seen this talk before, you know, I talk about the espresso machine or soda machine or something, you know, someday maybe we'll just push a button and all the other medication stuff just happens automatically. That's the dream. It's not practical today, but I think it's a useful thought exercise about how can we really simplify what we do rather than adding double checks and other things on top of it to make it more complicated. Because, you know, our job is very complex. The thinking piece is never going to go away. We're not suggesting that. We just want the execution piece to be much more simple and automated so that we're much less likely to make mistakes. Thank you.
Thank you, Dr. Grigg. Okay. Our next speaker is Monica Harbell. She's an associate professor of anesthesiology at the Mayo Clinic, Phoenix, Arizona. She's an associate chair of education and residency program director at the Mayo Clinic and current chair of the ASA Committee on Patient Safety and Education. Dr. Harbell will be speaking on barcoding and RFID.
Thank you so much for that kind introduction and for the opportunity today to talk to you about barcoding and RFID. How can we embrace innovation while dealing with all the challenges? My hope is by the end of this presentation, you'll be able to describe the impact of barcoding and RFID for medication safety. I feel like a lot of the talks earlier have kind of made that already, so that's good for me. We'll be able to discuss some of the challenges with implementation of these technologies, as well as strategize new opportunities that we have with these technologies to enhance safety. So everyone did this survey before. I really appreciate everyone that was able to participate. And surprise, surprise, a lot of us use barcode scanning in our hospital, but not many of us, probably to Dr. Ju's chagrin, use it in our operating rooms. And even if we use it in the operating rooms, we're not using it for every medication. And nobody's really using RFID scanning yet, and it might not be ready for prime time, but we'll still talk about it. So, I skipped some of these slides because my colleagues covered it really well. I think really just big picture, our goal by 2025 is to get to the point where we can have a machine readable code on all of our syringes and our infusions. And that we want to do this not only in our pre-op and our post-operative areas where many of us are doing it already, but we need to be able to find a way that we can do it intraoperatively. We've kind of heard about the barcode medication administration practice. So ideally, you're checking with the patient. Obviously, we can't always do that. So we're at minimum checking with the ID band and then scanning that and making sure it matches the computer and then scanning the medication and making sure it's the right medication and the right dose. And barcode medication administration is not new. It's been around for 20 years, but you can see that even in 20 plus years of a technology, it's still not incorporated intraoperatively. When it is employed, it can decrease non-timing medication errors with an absolute reduction of around 5% and a relative risk reduction of anywhere from 40 to 50%. It's been shown in some studies to reduce adverse events by 17%, decrease medication preparation errors by 50%, and medication preparation time by 60%. In one study, they actually showed that it decreased the length of stay by 4.6 days. That was in a chemotherapy unit, so obviously very different than our OR setting. And they try to make the argument that there could be a potential reasonable return on investment. There's a $2,000 cost of implementation per harmful error prevented compared to the cost of an error, which is anywhere from $3,000 to $7,400. So bear with me with one more audience response system. I probably tortured Arnie with all this, so thank you, Arnie, for your help with this. And I'm really curious what challenges with barcode scanning you've experienced in your hospital. And I know not everyone uses it, but I'd be really curious to see what people are going to say. I have some guesses. And we'll give everybody a moment. I think you can still use that QR code in the corner, and we'll kind of see our word cloud. He said I could do a word cloud, and I got very excited. It's clouding. Look at that. I love it. And I think we're starting to see some themes here. People are like, oh, as soon as you say something, I'm going to start plugging in something else. But but you're seeing a lot of things like the cost of it, the scanner itself, a lot of technical issues involved with it. Wonderful. Okay, so hopefully that will save. Unfortunately, I think this is an older version of my slides, but I'll try to big picture summarize. Unfortunately, there's a big limitation to barcode medication administration, and that is that it cannot completely eliminate medication errors. It does not prevent someone from bypassing the system. It does not stop someone from ordering the wrong medication. It doesn't stop a medication from being labeled incorrectly. And there are other buckets of how these barriers and challenges to barcode medication errors can happen. They can be technological issues where like the scanner doesn't work, or the medication is missing or has an unreadable barcode. And there can also be a lot of processes and system issues. I think a big one that my co-panelists talked about already was time. It takes time to scan the patient, scan the meds, check in the thing, and do all of this prior to administration. And sometimes that lack of time can really translate to increased workload, increased distractions, and that can also lead to people deciding to find ways to work around them. And some of those workarounds can be nullifying for the safety mechanisms involved. And it can also make people really hesitant to want to try to use it, which I think my co-panelists also alluded to. So I wanted to talk about what are ways that we can try to improve our implementation of barcode medication administration. And I think an important thing is to try to have as many medications as possible. Ideally, all of them have a machine readable scan. And ideally, that barcode is actually going to show up on that medication's primary packaging. So I was really encouraged by the talk earlier about how Francis is dedicated to doing that. That is going to decrease workload on the end user. And we got to figure out how we can redesign our technology to have it fit within our workflow. It's important that we continually evaluate the barcode medication administration's use. How often are people overriding it? How often are people actually using it with real-time observation? And obviously, we also need to be looking at how we can share what we learn in one institution with other institutions so that we all can benefit from it. I think there are some opportunities for barcoding as well. We've mentioned multiple times how in anesthesia, we're often it when it comes to medication administration. There is nobody to do a double check in 99.9% of my cases. And so, having a barcode mechanism to act as that double check, especially for high-risk medications or for infusions, can be really helpful. We heard about it's important to look at safety too. So looking at different workarounds that our staff use in barcode medication administration can not only allow you to see gaps in the current processes, but maybe a good way that we should try to adapt the system to better serve the end user. And I think it's really important to find ways that we can actually integrate the barcode medication administration system with our electronic health record, with our automated dispensing cabinets, to really make it a more seamless workflow for the healthcare professional. So RFID is a growing field in healthcare. And basically how it works is you have an RFID tag and an asset or a person. It is able to have a unique identification. It is able to store a certain amount of memory. Then you have an RFID reader that has an antenna that can communicate via radio waves and transmit information to, as well as receive information from it. The really important thing about RFID tags is that it's automatic and therefore very efficient. It does not rely on human intervention. There's lots of different types of tags that are out there. The big picture thing to know about them are the ones that have longer capacity or longer distance that they work at, or larger memory, tend to be more expensive and tend to be larger. There are lots of different uses for RFID in healthcare already. It's being used for real-time location for patients, for medical staff, for assets. If you want to find that video laryngoscope, you can use this to try to track it down in your hospital. It's used for monitoring medical equipment like gauze, surgical instruments, with the idea that after a certain number of uses, you'd want to take that surgical instrument out of circulation before it breaks in a patient. It can be used for monitoring drugs, especially expiration dates. It can be used in conjunction with wearable technology to be able to have remote and real-time monitoring of vital signs. They've even found a way to use RFID to monitor the pH of a wound to let you know when it looks like it's starting to get infected. That's pretty amazing. So obviously a huge pro is that it has automatic data collection. You can read multiple tags simultaneously from a greater distance than a barcode reader. In one study, it was actually found that it reduced the medication dispensing time by 61% compared to barcode scanning. A big con is the cost and data security concerns. The sensor accuracy may be affected by the power of that sensor, the location of the sensor, how many you have, and they can be susceptible to electromagnetic interference. So even putting a metallic object near it can act as a cage that blocks the RF waves. So how might we use it to enhance medication safety? Obviously, it can help us with patient identification, making sure that we have the right patient, right drug, right dose, and the right time. It can help reduce our medication dispensing time. They have a way with RFID technology to be able to have real-time capture of incremental drug administration from a syringe. So you can imagine it's collecting all that data. You don't need that additional cognitive load of trying to chart the infusion change that you made on the pump. It can improve the stocking of carts, our anesthesia carts, our drug trays. It could notify you if there's changes in vital signs in response to a medication. And it should be helpful also in identifying any counterfeit drugs that does not have the proper RFID tag. So asked before my talk and how effective people thought barcode or RFID would be. And it seems like the majority of people think it would be effective in helping them reduce medication errors. And so now it's really on us to figure out how do we make it attainable? How do we make it cost effective? How do we make it work in our workflow? So in summary, barcode and RFID technology can decrease medication errors. There's obviously huge barriers for us, especially technical issues, time pressure, and cost. Trying to learn from the workarounds and find ways that we can really integrate into our workflow are necessary for us to be able to successfully adopt it.
Thank you. Our next speaker is Karen Nanji. She's an associate professor of anesthesia at Massachusetts General Hospital and the current chair of the Perioperative Medication Safety Task Force of the World Federation of Societies of Anesthesiologists. Her research focus is on patient safety and the innovative use of technology to prevent medication errors. Dr. Nanji will be speaking on decision support software and mitigating medication errors.
Okay. Thank you for the introduction. Good afternoon, everyone. So today I'm going to discuss clinical decision support software and its use in clinical practice. My research focuses on patient safety and the innovative use of technology, in particular informatics and clinical decision support to prevent medication errors in the operating room. I also co-founded Guided Clinical Solutions, which builds adaptive medication safety software for the operating room. Here are my disclosures. So I'll start with some brief background on medication administration in the operating room, because it really sets the stage for clinical decision support that I'll discuss this afternoon. First, in the operating room, as Dr. Ju mentioned earlier, we don't have access to the safety checks that exist elsewhere throughout the rest of the hospital. For example, in hospital wards, there's typically electronic clinical decision support to provide important information as medications are ordered. Pharmacists then double check orders before they're dispensed, and two nurses, of course, check again prior to administration, and even scan the medication along with the patient's wristband. The OR is actually the only location in the entire hospital where these tools don't exist. And a single provider, the anesthesia clinician, is responsible for each of these steps. And in fact, there are no prospective orders, and the only electronic step is documentation after the medication is administered. To complicate the issue, the operating room can have a lot of time pressure, and the stakes are high because surgical patients are among the sickest in the hospital. So we completed one of the first studies to prospectively measure medication error rates in the operating room. And we found that about 4.2%, or 1 in 25 medication administrations at our center, involved a medication error. And these rates are in line with observational studies by Alan Mary in New Zealand and other medication safety researchers around the world. So here's the clincher. Because 10 to 13 medications are administered per anesthetic on average, this works out to greater than 40% of operations containing one or more medication error. So in order to address and prevent these errors, we have focused on clinical decision support, which are software algorithms that provide evidence-based information to the clinician at the point of care to assist with decision-making and prevent errors. And this has been shown in many other care areas to prevent medication errors, but has not yet been widely implemented in the operating room because of that unique way we administer medications in the operating room without prospective electronic orders. So through federally funded research, we used human-centered design principles to build a medication safety software platform called Guided OR that brings clinical decision support to the operating room. And we used an iterative design process that involved clinicians during every step to design algorithms that target 95% of the error types that we found in the operating room. So what did the human-centered design process look like? Well, there are 6 phases that we described in detail in a paper in the Journal of Applied Clinical Informatics. And each phase involved iterative user input and feedback. The first was identification of need. And this involved measuring the error rates to discover that medication errors in the operating room indeed are a problem. And also gathering data on solutions with evidence to support their efficacy in preventing medication errors. Clinical decision support emerged as a top evidence-based solution that hadn't yet been implemented in the operating room, but had plenty of data from other clinical areas like inpatient wards, outpatient clinics, ICUs, and others. The next phase was algorithm development. So with clinician input and feedback, we mapped each error we found to an alert algorithm that could have prevented it. For example, if we found that certain medication doses were not being adjusted appropriately for patients with kidney disease, we added an algorithm to automatically provide the doses for these medications to the clinician at the time of medication administration. The third phase was the determination of technical requirements. So with user input and feedback, we identified 3 technical requirements. The first was real-time functionality. Due to the rapidly changing patient condition in the operating room, the integration of real-time data into algorithms is critical. Also, individualized alerts that are tailored to patients' physiology, incorporating variables such as blood pressure and renal function. And the third is a workflow change. So we, as I said, typically document medications after administration, which is obviously too late for important clinical decision support functionality. We need the initiation of medication documentation to occur immediately prior to medication administration at that critical moment of decision making to indicate that intent. And there are many different tools that can facilitate this, including barcode scanning, RFID, and others. The fourth phase was system design, and this involved designing and building the technical system architecture and rules engines that power the algorithms. The fifth was user interface design. We worked with usability specialists and our clinicians to design alert windows that use concise, consistent language that's actionable and provide relevant context around the recommendations. And I'll show you in the coming slides what this looks like. And then finally, usability testing. We conducted comprehensive formative and summative usability testing, including a randomized controlled trial to assess usability, and I'll show you the results of that as well. So what does it look like and how does it work? So the clinical decision support launches instantaneously from the patient's chart and the medical record and receives relevant information, including the patient's allergies, medical history, the operation. Then the barcode on a medication syringe label is scanned immediately prior to medication administration. And we scan any type of syringe label barcode using any hospital-approved scanner. There's no proprietary hardware associated with this. The barcode scan triggers a clinical decision support to display a dosing window right on the operating room computer monitor on top of the EHR with pertinent information or alerts when necessary to prevent a medication error prior to the medication being administered. And I'll show you a demo on the next slide to illustrate this. After the medication passes through the decision algorithms, it's then sent to the EHR for automated documentation. And this part is key because it means that the clinician doesn't have to document the medication separately in the EHR by looking it up, selecting from one of many different formulations and inputting all of the details. So it's actually a much more efficient way to document medications. The clinical decision support also receives real-time data like vital signs and intraoperative laboratory results, and can send reminders, for example, to treat blood pressure at an individualized patient threshold or to check laboratory values when needed. And we have this fully integrated with the EHR at Massachusetts General Hospital and are at various stages of implementation at additional sites around the US. So I'll show a demo video now, and I think it's useful to visualize the workflow with clinical decision support. On the top right, you'll see a video that shows medication scans. So you could see what the workflow looks like to scan medications prior to administering them. On the main screen, you'll see what happens on the OR computer monitor when the medications are scanned. And we'll start with some examples just to show you the workflow that's used for clinical decision support. And then I'll show you the actual clinical decision support and some of the information and alerts that you might see. So here's the first scan. Let's see. So you'll notice there's an optional audio readback that works synergistically with the visual dosing window to help clinicians recognize if they've scanned an unintended medication. On the dosing window where applicable, there's a default dose shown that's specific to the patient based on their age or weight or renal function or whatever the relevant factors are for that particular medication. Of course, you can enter a different dose in the free text box, but with this pre-selected dose, all you have to do is click save, or you can cancel if you change your mind about administering the medication after the scan. So here we'll click save, and then the medication is sent for automated documentation. The next thing that many people ask about is induction and what this workflow would look like during induction when multiple medications are given in quick succession. There are a couple ways to do this, and it really depends on the clinician's preferred workflow. So if I'm working by myself, I like to quickly scan all 4 induction medications immediately prior to when I administer them. This gives me that safety check. And then I can focus on the patient and on induction. So for example, you could see here that the patient has an allergy to rocuronium, and we're alerted of that and reminded of that immediately prior to administering the rocuronium. So we have an opportunity to select an alternative muscle relaxant. So we'll go ahead here and scan succinylcholine. Then we can go ahead and focus on induction. One more workflow item that people often ask about is emergency situations and what happens during emergencies when there isn't even time to label a syringe. We all know that that can happen, but during these times, chances are you have a vial in your hand ready to drop and administer. So you can actually do a quick scan of the vial itself to even give you a safety check during emergency situations. And importantly, that scan will also timestamp the administration so that when you go back 45 minutes later, once the patient is stabilized, you know what medications were given and what time. So it actually helps with your workflow efficiency and documentation accuracy after the emergency situation. So in this case, when we go back to document, it's a quick click on the dose and everything is sent to the EHR for automated documentation. Now I'll show you what some clinical decision support algorithms might look like with this workflow. So this patient has an allergy to penicillin. So we'll go ahead and try to give clindamycin as an alternative antibiotic to cefazolin. So the software knows that the patient has a penicillin allergy. It knows the severity of that allergy and the reaction and the operation. And it knows that cefazolin is still the recommended antibiotic for this particular procedure, despite the penicillin allergy. And we know that 5 different clinicians will do 5 different things in this setting. So it's important to have the clinical guidelines at your fingertips at that critical time of decision making. And of course, many of us, when we see a recommendation, want to know the source of the recommendation. So right next to any recommendation, you can pull up the source, in this case, the hospital guidelines for penicillin allergies and cephalosporin allergies. So you can pull them up at the point of care if you want to see those along with the recommendation. In this case, we'll administer the cefazolin. And you can see, as with all antibiotics, the dose is pre-selected here for the patient, in this case based on the patient's weight, and it could be based on age or weight or renal function or whatever the relevant factors are, but you don't have to think about what the dose calculation should be for that patient. Of course, you can pull it up right next to the dose if you want. You can pull up the dosing guidelines and see the calculation right there for why that recommendation is being made. In this case, we'll just click save, and that gets sent for automated documentation. The next algorithm I'll show you is one of my favorite types because it's not a pop-up alert at all. It's information that's integrated right into the dosing window. So here you see the dosing window for ketorolac, and it's telling you the patient has renal insufficiency with a creatinine clearance of 31. So the dosing options you see here for ketorolac are 7.5 and 15 milligrams. Notably, 30 milligrams is missing, and that's because it's not a safe dose for this patient. Of course, if the clinician wanted to give 30 milligrams, they could still enter it. But we find that by removing that option, essentially all the clinicians choose a safe option. So it's making the safest option also the easiest option. And in that way, we get safer care. So of course, we have many algorithms. I'm just showing a few here for the sake of time, but hopefully this demo gives you a sense of the types of algorithms that are available with clinical decision support. We completed a retrospective cross-sectional study of anesthesia safety reports that we recently published in Anesthesia and Analgesia, where we looked at 2 years of safety reports at our institution to determine how many of the errors could have been targeted or prevented by clinical decision support. There were 80 safety reports related to medication errors during the 2-year study period, and you can see a breakdown of the error types here. Notably, 95% of the errors were rated as preventable by clinical decision support by independent reviewers, meaning that clinical decision support can target 95% of the medication errors that were reported during that 2-year period by providing information or alerts intended to prevent them. And finally, we conducted a randomized controlled trial published recently in JAMIA to compare the usability and effectiveness of clinical decision support to the current standard workflows. And we found that clinicians who use clinical decision support had a more efficient workflow. They actually saved 20% of their time on medication administration and documentation. And these efficiency gains were due to 2 reasons. The first was obviously the automated documentation, but secondly, and more importantly, the clinicians arrived at their clinical decisions faster and more confidently with the clinical decision support software. We also looked at quality of care metrics, and essentially all of the metrics that we measured were improved in the clinical decision support group, including patients had tighter blood pressure control, more accurate medication dosing, and better pain management. And finally, we looked at user satisfaction and usability, and the usability scores on first-time use of clinical decision support software were double the EHR usability scores, and we used summative usability scores in our testing. So in summary, the operating room is missing standard medication safety checks. Electronic clinical decision support with barcode scanning improves both quality of care and workflow efficiency. User-centered design is critical, and next steps include wider implementation and large-scale multi-center trials.
Thank you. I'd like to open up the floor for questions. We have microphones on both sides if you would like to come up. I see Amy Vinson. Go ahead.
Yeah, I just have a question about the decision support tree and whether when you have a prompted decision support question that leads to a change in decision, is that considered a near miss? And if so, are we tracking the number of near misses? And as a corollary, does that give us a window into sort of the scale of self-underreporting that we've been using for years for medication errors and near misses? And sort of a two-part to that, both in the OR and with pharmacy ordering. I know I have changed my order multiple occasions with pharmacy prompts ordering things. I don't internally consider those near misses, but should I? Because I would have totally written those in a written chart.
Great question. So yes, those things can all be tracked and analyzed and studied and reported on. So we do have that. And is that in your miss? I would say it depends. We need to analyze that. Could there be other factors? In some cases, it's an appropriate, let's say the decision support tells you to take an action. You could accept it or you can reject it or override it. Let's say you override it and go against it. In some cases, that could be appropriate. And in other cases, it's not. So those things are all tracked, but I would say you can't just blanket analyze them. It requires a deeper, you need to go in and almost do a chart review, and we've done those kind of studies, but that's how it needs to be done. I can't remember the second part of your question.
You pretty well answered it.
Hi, Eliot, this is for you. You showed one slide that had on the top a segmented drug administration pathway for most places in the hospital. And then on the bottom, it was just like a single pathway that we use in anesthesia. And you mentioned how that could actually be advantageous. I don't recall any examples or description of how that could be so. Can you do so?
Yeah, well, I mean, I actually think I have a pretty good example on the end here. I think the challenge with the first model that most of the hospital uses is that nobody has control over the whole process. Everybody kind of owns their little piece of it. And so nursing has their piece and the IT people have their piece and pharmacy has their piece. I think we have an opportunity to provide more customized solutions. And I think this clinical decision support is actually a reasonable example. I have lots of questions, I'll attack you with later, but, or things like pre-filled syringes or automatic programming of pumps or, various things that we could do that might be harder to implement in the rest of the hospital. I mean, color coding is another one. Most of the hospital doesn't really like it, but I think it's to our benefit. So I think what I have experienced in the past is people say, well, this works great on the floor, do that in the OR. And that's what worries me. But I think, I think there are ways that we can behave because we control the whole thing in terms of how we document, in terms of how we order or not order, that the rest of the hospital doesn't have that flexibility.
So would you consider those to be workflow types of advantages, or is that something else altogether?
Yeah, I mean, I think it just means we have the opportunity to control the entire process, for better or worse. It creates liabilities for us, but also opportunities to do things uniquely based on how we operate different from the rest of the house.
All right, thanks.
Great. We'll go over Dr. Dutton.
Thank you. Dr. Nanji, if I recall from your 2014 paper, a lot of the medication errors you charted at MGH were things like hypotension after induction. How does your CDS help with that? If I'm pre-scanning my propofol dose, does it tell me 120 is too much, you idiot, give 80?
No, propofol is something that you would titrate clinically, so you can enter a dose afterwards. It would suggest doses for things like antibiotics that would have a set dose for that particular patient based on whatever relevant patient factors there are. But I would say in terms of hypotension being an error, it would only be considered in that realm if it's untreated. So patients can get hypotensive after propofol, and that can be a normal reaction to propofol or to the surgery or to some other thing. So it becomes a problem when we don't treat it after certain periods of time. And I think we have good data to show the longer significant hypotension goes untreated, patient outcomes can deteriorate. So in terms of how do we get at that with clinical decision support, we have patient-specific reminders at certain blood pressure thresholds that can be, that are based on baseline blood pressure over the prior 3 months of outpatient visits and looking at whether or not they have underlying coronary artery disease. And we pull all of these data from the EHR to get to customized blood pressure thresholds. So we might not realize preoperatively what the patient's true baseline is, but to have that as a comparison and to know how far they can drop from that is where clinical decision support can be helpful in those types of failure to treat events.
Thank you.
Great. Go ahead.
Adrian Gelb, a couple of comments. Rick AI will be able to start doing that probably in about 10 or 15 years through personalized medicine approaches. And Karen, I disagree with you. Hypotension is always an unintended, undesirable consequence, and therefore by definition is a medical error. But that wasn't what I intended to say from the microphone. I just wanted to make a sort of editorial comment and draw people's attention to what we've been seeing visually in a lot of slides, but perhaps not thinking about it concretely. I've developed over the last couple of years an interest in why implementation of patient safety fails, and I've been dabbling in implementation science, where Donald Rumsfeld was one of the great proponents of it with his known unknowns, is that from implementation science, the implementation of something like patient safety fits into the unknown unknowns. It's about human behavior. And I think any of us who have children know that changing the behavior of one child requires a different strategy to changing the behavior of another child. And that changing behavior is context sensitive and it's iterative. And what we've seen in a number of slides, including Stephen's last slide, Matt's last slide, is circular phenomena. And as clinicians, we've all been trained to go in a linear fashion. We think about diseases linearly. It's always the most logical. Human behavior has no logic to it. And so in order to implement effectively, we need iterative implementation, that our hospitals need to understand that in order to make this change, we're going to go through this loop multiple times, modifying it, and that's going to cost you money and time.
Thank you.
Can I
Of course.
respond? An excellent point. I quibble a little bit with human behavior is completely unpredictable. I would say it's probabilistic, and with appropriate study, with appropriate techniques, you can get pretty close for 90% of 95% of the situations. But as any medical device manufacturer will know, you do all the testing you can, you get your product out there, and things happen that you just couldn't possibly have conceived of. And that's why we need our systems to be so resilient.
Great. Do we have some online questions? Go ahead.
Thanks, Emily. The question this time is, are there available resources for an organization to do a self-assessment of their policies, their SOPs, really looking at human factors so that they can lead to decrease in errors and perhaps really improve their policies and procedures related to medication error? I started to do the research. I didn't have time, Mark.
I mean, there are lots of guidelines and standards and textbooks on human factors in healthcare. My concern with leaving it at that is that there's no, just like for clinicians, you don't send someone to deliver an anesthetic who's read all the books and nothing else, right? So you need experts. And so my advice is a hospital that wants to implement a human factors program needs to hire someone who knows how to do human factors, at least to get them started. And part of that process should be to train the trainer, to really educate the people who are there so that they can take over. But you can't do it, just like a medical device company can't just say, hey, you're an engineer, figure out human factors and do that for us so we can get FDA clearance. That doesn't work too well either.
Okay, thank you. That was just one.
Steve Greenberg.
This is sort of a specific question to clinical decision support. there are a lot of what I'm seeing in Epic and other electronic medical record systems where things are default checked in order sets, common like medications that are being duplicated within the operating room. Is there a system, particularly yours, Dr. Nanji, that actually identifies drugs outside of the operating room space that can then alert you not to give a similar drug, IV, within the specific duration, okay, not just, but the specific duration of that common drug that might be an oral drug? We see, in my own experience, that there's not as much crosstalk between pre-operative orders and the intraoperative anesthetic record with regards to that oral versus IV exchange of medications and alerts.
Yes, absolutely. I think it's critical to pull that in, and we do pull that information into the decision algorithms. Common ones are Tylenol, preoperative Tylenol, antibiotics, NSAIDs. These are often re-administered intraoperatively, so I think it's critical to check for that. Yes, and yes, the system does that.
Great, thank you.
Can I ask a follow-up? So what about post-operative? It's my experience that nobody other than the anesthesiologist and the recovery room nurse know anything about what we did in the operating room from a medication standpoint. And for example, we're using a lot of methadone. And I think that people on the wards that are prescribing pain medications ought to know that, but nobody goes and looks at the anesthesia record. Is that something that, have you thought about that?
Yeah, so when the software is being used, it would alert people. So it depends where it's being used. Right now at our institution, the software is in the operating rooms only. So if it were used post-operatively, they would be specifically notified. But if you're using the regular EHR, as most institutions do post-operatively, it would be in the MAR as it currently is. So they have to find it in the MAR.
Thank you so much. I want to thank our panelists again. We're going to transition to our next session on opioid safety, and I'm going to hand it off to Ken Johnson.